Hi, welcome. Thank you all so much for joining us. Right now we have 42 people on the call and more just keep joining. I do want to give everyone a heads up that this webinar is being recorded. So thank you all for joining. Some super quick Zoom 101, Zoom etiquette. We have almost 200 people registered for this call, and we don't have the webinar setting in our Zoom account. So this is just a regular Zoom call. We do ask to please keep yourself muted throughout the call and to manage Q&A at the end. We would prefer to take those via chat. If you can't use the chat function, if you're calling in from a phone, totally fine, feel free to speak up. But if you can use the chat to submit questions, please do. We also want to make sure that everyone knows that streaming your video is totally optional. That is not a requirement by any means. And for those who might be new to Zoom, if you want to make sure that the biggest picture is the person who is speaking, in the upper right corner, you can click on speaker view, and clicking on that will make sure that the person who is speaking is the largest video that you see, so that you're not just staring at a sea of faces while one person is talking. Again, just want to repeat, since we've had a few more people join us, if you do have questions, please submit those in the chat. And by all means, thank you for getting us started. If you want to send where you're coming from, where you're tuning in from, please do in the chat box. And again, if you have questions for the panelists, please submit them via the chat unless you cannot use the chat for any reason. So with that, we're going to get started. My name is Molly. I use she, her pronouns. I'm the organizer for the Missouri HIV Justice Coalition. Here in Missouri, we are one of 34 states that have an HIV-specific law or sentence enhancement. And in Missouri, our laws are particularly punitive. We're going to be talking more about that as we get going, but I'm turning it over to Eva, our co-moderator today.
Thank you. My name is Evonnia Woods. I'm the Missouri organizer with Reproaction, which is a national organization. We have people in various states and regions. We work on increasing access to abortion and advancing reproductive justice. And one of the issues that are a part of reproductive justice is HIV. And AIDS and access to care and treatment, and in general, and just how people are able to, function with that. And you want me to just continue and roll into the next portion? I'm gonna my pronouns are she, her, and then I'm gonna kick it back to Molly and we'll get started with panelist introduction.
Great. So our first panelist is Kneeshe Parkinson, she, her. Kneeshe started Kneeshespeaksstl, where she speaks about her lived experiences as a woman living with HIV. But Kneeshe, I'm going to turn it over to you to give yourself a more thorough introduction of yourself. So what has been your role in addressing HIV and AIDS throughout your life and your career? If you want to just tell us briefly.
Good evening, everyone. My name is Kneeshe Parkinson. I am the founder of Kneeshespeaksstl, Lived Experiences. I am a woman living with HIV, and I've been diagnosed 23 years. This July will mark my 24th year as living as a woman positively in my community of St. Louis, Missouri. I am a phenomenal woman who is building community engagement for all women living with HIV worldwide. I'm also the co-chair of International Community for Women, North America as well. So I tailor several different hats that I wear in the community on a national and international level. That's just a tidbit about me. You'll find out more about me throughout the session. Thank you for being here today.
Great, thank you so much, Kneeshe, and thank you for taking us to the beach today. I think we all need that.
Yes.
All right, next we have Antoinette Jones, she, her, who is the peer navigator at SisterLove. Antoinette, do you want to tell us your role in HIV advocacy?
Yes, so hi everybody. I'm so happy to be here. My name is Antoinette Jones. I work at SisterLove Incorporated in Atlanta, Georgia. And I've been doing HIV advocacy for the past 3 years when I started my position at SisterLove. A lot of the work I do is around HIV testing and counseling, education around HIV, linkage to care services, facilitating groups, and then I also travel to different locations to do education around HIV and transmission, sex, and disclosure, just informing the community about HIV and AIDS. And a lot of it is mostly sharing my story and sharing my experiences. I was actually born HIV positive, so I've been positive for 25 years now. And it's really like all I know. So I'm happy to be here, like I said, and I'm happy to share information and learn some stuff from you all.
Great. Thank both of y'all for agreeing to be on this panel. Our next panelist, want to introduce J. Marie Hill. Pronouns are they, them, and they are the Trans Justice Organizer at ACLU, Missouri. And Jay, you have, if you can answer the same question, like what's been your role in addressing HIV and AIDS throughout the year?
Hey everybody, can you hear me okay? I think we're good on the hearing front. Thank you for having me, and it's an honor to be on this kind of webinar with all these brilliant minds. So yes, indeed, I am at the ACLU, and I think I'm a similar person to the masses in the sense that, you know, maybe I didn't know a lot of people. My family wasn't talking about it as a younger person, but the way I came into it was really from the art that was created as a you know, tribute to those that were lost. And so from there, as a Black, queer, trans person, I knew that meant that I had a lineage to uncover and a lot of digging to do. And so that has, you know, brought me into the work from that kind of artistic identity lens. And then now I'm a member of the, sorry, I got some family stuff going on, but I'm a member of the Missouri HIV Justice Coalition, partly because, you know I have a lot to learn in terms of being involved in the HIV community, in terms of folks who are moving through it and navigating it, but also to make sure that trans folks, men, women, non-binary folks are included in the conversation, because it is a developing conversation for many people. And while that is my priority, and you know that means we have to talk about HIV, we have to talk about people living with HIV in the ways that most people don't think of it as something that is at the top of their minds, but definitely should be something we talk about beyond the art, right? Making sure that people know people are living with it now, right? And that we have a lot of work to do to keep that from getting worse.
Thank you for joining us this afternoon and for that great description of your work. Our next panelist is Amir Sadeghi. You'll let me know if I got that wrong. Pronouns, he, him. He's the National Community Outreach Coordinator at the Center for HIV Law and Policy. And Amir, I'd like you to answer the same question. So, like, what's been your role in addressing HIV and AIDS throughout the years?
Yeah, thank you for having me here. It's great to be here and, you know, see some of your faces again. My role, well, you know, the Center for HIV Law and Policy is a national legal resource and strategy center for people living with HIV and their advocates who are working together to challenge legal barriers to the rights and health of people living with HIV. So what I do is I help implement the Positive Justice Project, which is it's actually the first national collaborative of individuals and organizations who have been organized to end the criminalization of HIV and other stigmatized diseases and identities. So from end to end, what I get to help do is help publish resources and distribute them to state level advocates, to helping with coalition building and engaging criminal legal stakeholders. And you know, some of what we do, we have our some attorneys who provide some legal guidance and do some bill drafting. So really from end to end, from the coalition building stage all the way to supporting state level advocates as they go through the process to get their bill through the finish line. And that national collaboration is actually built on a set of guiding principles that was drafted by the PJP advisory group. So, you know, it's informed by lived experience, but it's also kind of fueled by legal expertise of HIV criminal law. And really one of the fundamental goals is to ensure that a legislative proposal won't reinforce the criminalization of any left behind key affected groups. So that's really one of the major guiding principles of the Positive Justice Project, and I get to help implement that with state level advocates across the country.
Excellent. Thank you so much. And thank you to all of our panelists who are joining us today. And thank you for co-moderating with me today, Eva. So today we're talking about examining Black women's health at the intersection of HIV, IPV, and the criminal legal system. For those who maybe have never heard the term IPV, that stands for intimate partner violence. A lot of people also call it domestic violence. We can get into the weeds of that another time, but for our purposes today, we're using the term IPV. So there are a lot of layers behind what we're going to be talking about today. So we're going to start piece by piece and then build up to it and pull it all together. So first, we're going to talk about HIV, general HIV information, and general HIV language. So at the core of any discussion around HIV, it always becomes clear that so many people still believe outdated information around HIV and still use outdated language. So first, let's hear from Kneeshe. Why do you think language and how we speak about HIV matters when it comes to people's ability to navigate finding good information about HIV? Why does language matter?
Language matter, and I'm going to do it for me as a person living with HIV and individuals that I service and advocate for. Having that conversation in regards to language and how you're being treated and to reduce stigma, it matters wholeheartedly for our people to thrive, to people to be able to seek information and have that authentic information 100% of the time in their communities. It reduces stigma if you have a comfortable conversation with a provider or with a peer or with a health coach or with just your case manager or your social worker that you may be working with to receive services from, like the Ryan White services that several people receive throughout the world to be able to navigate through those services that they need to stay healthy, right? So if you don't have great bedside manners or great language, you do yourself a disservice and the person that you're servicing, realistically, a disservice. You make it harder for them to want to come into care, unapproachable. All of that is a factor in language. I remember when I came into HIV services for myself, I was paired up with a young social worker by the name of Jessica Forsythe. And she approached me in a way that was meaningful for me to really understand. She was new to the social work field as well. So we both were learning at the same time when she came on board as a social worker. So that afforded me a little more leadway during that time as an adolescent at 17 years old. You don't even know which way you're going the next day of the week, you know, let alone getting a new diagnosis at 17 really struck me in a different manner, and I really didn't know what to do. So she provided that language, that education, that compassionate feeling to support the unknown for me. So that's why language really matters in my perspective as a woman living with HIV. And I hear it so plainly in clinical settings that, you know, physicians have to use better language or better bedside manners to cultivate the movement of an individual who just don't know about their statuses and the education and just being there, you know, and talking over a person's head is really demeaning to a person that's coming into a new space.
Absolutely. Thank you for that, Kneeshe. Antoinette, what would you add to that? Why does language matter when we're talking about HIV?
I definitely agree with everything Kneeshe said, and I'm just going to piggyback off of what she said around stigma. So language can be very stigmatizing, especially when referring to people by their diagnosis. So they either get like consumed or identified with that diagnosis. So we want to be like sure that as we're moving forward, that we want to change language and change how we speak about people living with HIV. And then another reason, language is fluid, you know, so as we grow in the world and as the world is changing, we want to advance with the world. We don't want to use ignorant language or uneducated language, especially, like I said, as we're moving forward. So, and as we're advancing. So using people first language and not making the person, their diagnosis is very important when having conversations or when using language around HIV. So.
Absolutely, thank you. And I love that both of you spoke to how language is fluid and it is changing, how Kneeshe talked about how her and her social worker like learn together, and Antoinette, you pointing out that language is fluid, it's always changing, we're always improving how we communicate around the topic. So thank you both for that. Amir, can you speak to why people are lagging so far behind when it comes to current information? And what are ways that people can be getting up to speed?
Well, I think right now you're seeing a lot of webinars and collaboration, which is great to bring people up to speed, but to get that information, to get relevant information to the people who need to see it, to people and communities who might be hard to reach, people who might be targeted by HIV criminal law, I think we need to see more cross-movement organizing. I think there's got to be, the movement to reform HIV criminal law can't happen without engaging people who are actually being targeted. And I think HIV networks are important, but we need to engage sex workers and harm reduction, racial justice organizations, criminal justice organizations, anti-poverty groups in a state. And I think specifically one way to really boost that is, I think, a concrete way to boost consciousness raising is funders need to directly fund state level networks, state level groups, grassroots advocates and organizations, and they need to put the money directly in the hands of people with lived experience of HIV criminalization. I mean, I think people with an intimate knowledge of what's going on in their state, they know what needs to be done. And I think they just, funders need to do a little less providing money to national organizations to then guide that and really just fund directly those grassroots cross-movement groups.
Absolutely. And I think that there's a connection there too with language, that when the people most impacted are leading, the language follows suit. The language that should be used is what starts to be used. So yeah, thank you for that. And thank you for that reminder that funders need to be funding the right people. Kneeshe has something that she'd like to add to her comment earlier about language.
Amir, I agree with you as well in regards to the language. It hones in on the humanity and the dignity of individuals living with HIV. And if we don't provide the key pieces for those individuals, who will we be harming? We will be harming those people living with HIV if we don't readily and availably have funding available for them as well, nurturing levels with them as well, and having access for all, right? So we have a diverse panel here today, and we want to make sure that we have diverse ability for everyone sitting at the table and let our voices be heard. Thanks, Molly.
Yeah, you bet. So let's hear from J. Marie. J. Marie, you talked a little bit earlier in your introduction about sort of your journey into learning more about HIV. What can folks do? What can folks do on their own to find information and stay informed about HIV?
Yeah, totally. Sorry, I had to unmute. Well, it's funny because I think so many people on this call are actually in their own way experts on this issue. So I think I don't want to preach to the choir, right? I think people are absolutely have found their calling in some way, even just to be on the webinar itself, right? To say, wow, this is something I want to be informed about, and I want to be, on the cutting edge of what is new. But I think a couple of things that I would offer for this question are, I think, become familiar. One, as people have said, the main thing is always to be proximal, to be close, right, to people who have experience with communities who are impacted by HIV, or people who are living with HIV, right? And because it's not always going to be possible for people who are living with HIV to be well-spoken or specifically, you know, ready to talk with you on a panel. Like, that's not necessarily the life that people are living. And I don't think we should always even expect that, right? Of people are living their lives. They don't necessarily want to be spokespeople, right? But when it comes to recognizing ASOs specifically, I think just those 3 letters, a lot of people don't know what that stands for, which is the AIDS Service Organization. We could talk probably all day about some of these terms that have followed us, right, through the years, but I think people not knowing that ASOs are a crucial way that not only does community get informed, people who are living with HIV and get their services, you know, their needs met, but also that that's an organizational kind of vector in terms of like where people can find out more, right? So maybe they're doing direct services, but they're also probably doing advocacy. They're also probably doing, you know, we'll pull up a truck at your event, right? There's ways that we can actually be closer and kind of bring in to proximity like each other's work and each other's efforts. And so I think becoming familiar with the basic terminology in a more contemporary way is definitely one of the hopes that I would have for folks. And for those of us who do this work already, really being unapologetic, right, about people living with HIV, reaching out to folks, getting people familiar with the terms. Like, if you do a thing about trans folks, or if you do a thing about LGBT things, there should not be a lack of a mention of HIV, right? Like, this is something that people are still living with. And if we don't talk about that, we're only playing into like the stereotypes and only kind of continuing the stigma. So I think just making every effort to basically, you know, if you do a glossary kind of post, or you just kind of offer up some terms, just add that, you know, PLHIV in there, just making sure people don't forget that there are still people living with it, and that you are personally, maybe as an organization, doing your part to keep people informed and not let people get away with what we know as historically, obviously, poor language and other ways that we've ostracized people who just happen to be living with something that people nowadays know a lot about, living with the virus or living with something that impacts you to the point where there is a stigma. So we want to break that in every way possible. And I think language, as folks have said, is one of the main ways.
Yeah, and I appreciate you reminding us that folks who've been living with HIV already know how to live with a virus. And so during this current pandemic, we have so much to learn from the HIV community about how to move forward. So thank you for that. Eva, I'm going to turn it over to you.
Yeah, so now we want to get into just a small shift into a conversation about transmission rates. The statistics that guide us in this conversation is that Black women account for about 60% of all women who contract HIV annually. So that's for new cases every year. About 60% of all the cases, new cases that come up annually is actually Black women. So, you know, it makes sense that we should be centering Black women in these conversations, thinking about when we talk about access to treatment and care, and that we should be thinking more critically about making sure that Black women are at the center of that work, because clearly we are failing them. But another statistic that guides us is that trans women are 49 times more likely to be living with HIV than the general adult population. So we want to be, you know, thinking about Black women, making sure that we're really, you know, hyper-vigilantly, I think I might have made that up, but including trans women in that conversation with Black women. Antoinette, for you, why is the rate for Black women who contract HIV so high? Can you speak to that, please?
Yes, so what do we know so far? We know that in the US, women at high risk of HIV are most heterosexual Black women, and that they're living in low-income areas without access to proper treatment or testing, or in places where HIV incidents are relatively high. So think of Atlanta, think of the southern states. And then also you want to look at women in rural communities who are impacted by that, who have limited resources as well. Like in the city of Atlanta or in Atlanta areas, we may have a lot of testing services and resources, but what about folks who live on the outskirts who don't have, like you said, access? So there aren't public transportation ways for them to get to a testing location. And then we also want to look at who didn't receive comprehensive sex ed. Me just being a youth engagement type person, I always look at the school system and how especially in Georgia, we have abstinence-based only. So if you're receiving an abstinence sexual education, then you're not receiving the education that you really need about your sexual health, about your sexual well-being, what sex is, and does it identify with who you are as a person? Is it heteronormal or heterosexual-based sexual education, which we know that everybody does not identify as heterosexual. Does it identify to what you identify as your gender, sexuality? All of that encompasses into sexual education. And if we aren't receiving that, then of course we're going through life, as I like to say, willy-nilly. And my experience is just doing testing and counseling and asking people, like, what do you know about HIV and AIDS? How is it transmitted? A lot of what I hear isn't based on scientific research, of course. It's very stigmatizing, what they hear in their communities, what they hear from their friends, their girlfriends, their Judies, anybody. And then, or they just don't know anything at all. So if people aren't receiving the education that they need, the tools that they need, then they aren't going to know much about HIV and AIDS. And then, of course, the transmission rates are going to be higher. So that's why, of course, at SisterLove, we don't just test for HIV and AIDS. We make sure that we are counseling you. We are giving you the information and the tools you need, because just because you're negative, we don't want to just send you on your way. What does negative really mean? How do you remain negative? How do you protect yourself, prevent any types of transmissions, whether it's HIV or any other STIs or STDs? So I think education is very important when dealing with this. So.
Yeah, I wholeheartedly agree with you there. I was like, if they don't mention sex ed, I will. But I should have known you were going to bring it up. Yes. Okay. And Kneeshe, do you have anything that you'd like to add to that?
I want to really talk about the mental health pieces around, women living with HIV or not, women that are not living with HIV and that may walk into a space to get tested. That mental health piece, that substance abuse piece may be a factor for a young woman. Women over 50, we have a different spin, when you get to that 45-ish, 50 nickel range, that looks totally different. It's a lot of overwhelming feelings that you have and things of that nature, and transmission rates can happen very high in those age brackets. If you look at the trends and the data that is out there, the women ages 45 through 55, they're finding love again, and they really haven't had those conversations about sexual health and what that looks like, and they may still have some of that errored health literacy that they have from their mothers and their aunties and cousins and sitting around a room and talking, but the evolution of HIV and health literacy has changed. Access to healthcare, access to housing is a factor too, as well as Antoinette has mentioned as well. Another caveat to that, we are nurturers, we are matriarchs of the family, and we forget about ourselves. We go on the hustle and bustle every day, and we're trying to figure it out, and we're moving about the country and checking in and checking out of places, making sure the kiddos are in school and they're doing well, field trips and all of that. So we put ourselves on the back burner, and it may be something wrong with us. We've dealt with a pain for 2 days or 3 days or 4 days, and on that 5th day, we'll try to get to the ER or the urgent care or call the doctor, but we kind of let stuff fester and nester a little bit too. And sometimes the stigma in the community sheds a different light too, because you may have 5 or 6 friends that you really know that are positive, and you've heard them have conversations about their risk factors too, but you don't want to engage into that conversation with them because you know that stigma is an issue, or you don't want them to think of you differently, and you may not have that sister or a queen that can help you walk through those navigational pieces as well, to even seek help. It's scary walking into a clinic, to get any type of care done, not just HIV care, any type of care, because you're wondering who's looking, who's watching, so you're looking over your shoulder. So hopefully we can help with this session today and many other sessions that may be diffused around the country to reduce that stigma greatly and allow people into spaces like this so that they can be educated.
Yes, I think both of you did an excellent job of complimenting each other. I'm over here wondering if y'all talk to each other while y'all were coming up with your responses. So like, girl, I'm gonna talk about this. Okay, you talk about this. Yeah, y'all, I can't think of like a better comprehensive response than the one that you two just provided. It is for so much about access, and access doesn't just mean, you know, access to a clinic space. Who are you walking in to see? How are they talking to you? And what that experience is, because adjacent to that, we know that Black people's experiences in healthcare facilities is not up to par. It's particularly Black women's, and, you know, not just their, you know, beliefs about how much pain we can stand, but also just about our health in general. Like, it's just not taken as seriously. Okay, and so thank you both for that. And so, J. Marie, can you speak to, you know, why the rate for trans women is so high? Just a reminder again for everyone, trans women are 49 times more likely to be living with HIV than the general adult population. So, J. Marie, I want to give you an opportunity to speak on that. And then if anyone else wants to add to that, you'll get your opportunity. But J. Marie?
Yeah, totally. And I definitely, so one, as someone who's not a trans woman, I definitely like, and I don't know if there's any trans women on the panel. If there are, please, you know, add your thoughts in the chat. But again, I don't want to position people as needing to be a spokesperson. I think for me, what I would just urge people to think about is the combination of layers of, oppression is of course there, but really, I think it's just reality, right? I don't want to use big words. It's like you walk into a doctor, right? First of all, as Kneeshe said, whether you're trans or not, most of us kind of put off going to the doctor sometimes. It's not the most exciting experience, right? It's, you know what I'm saying? You want to be bothered with it. Insurance, which we didn't even talk about at all yet. People don't have insurance, right? And if you do have insurance, it's a lot of money still to maintain, keep up, get yourself situated, get your card, have a stable mailing address to get your paperwork. We're not even talking about getting to the doctor yet, right? So we're talking about just the initial kind of barrier, right? And then once, say you do get to the doctor, right? You have somebody disrespecting you, most likely disrespecting you based on your name, based on your body, based on your, you know, health or lack of it, which is such a, you know, generic term at this point. What is health, right? It's really just something to be wielded against people often. Especially, you know, those of us who exist at these margins, as if, you know, identifying in the margins means a death sentence or a way for you to say, oh, you can be on the margins and all of your care and all of your support can also be marginal, right? When we say we're on the margins, all that means is maybe there's not that many people that have our experience. That doesn't mean anything about our worth. That doesn't mean anything about what we deserve. That might mean that more people don't have the tools to like meet us right where we're at. And so, of course, then that puts it back on us as people who are living at these intersections of reality. So that might mean, you know, for folks who are trans, they might be doing sex work to make ends meet, right? Which is a power dynamic exchange, essentially, right? Some people might be, the product might be a myriad of things, but you don't always necessarily like have the power to decide fully how that goes, right? Even though money is exchanging hands, everybody is different in terms of how they move through that service. And then you have things like hormones, right? Again, if we don't have access to the doctor, you probably getting your hormones from somebody somewhere that may or may not be, you know what I'm saying, clear to pass out their, you know, their supplies and things like that. So hormones lead to needle exchanges, need to, you know, sharing needles possibly, as well as like folks have mentioned, harm reduction relating to drug use and things like that. People are just at the intersection of holding the world up, right? Just to live in their bodies means they have to hold up all these different systems and ideas and words and break down these systems and ideas and words. And so, I mean, I could go on all day, obviously, but I think the main thing is, as folks who are maybe doing this work on the call or people who want to get more involved, the reality is like, you have to be clear about, again, getting into proximity with trans folks, trans women specifically, and making sure that if there is a service that you want to provide that community, not only have you talked to people about it, but you're able to provide things that people need, like, and want in their regular everyday life, as opposed to just prioritizing them as a person to receive a service or a person with a designated identity that they don't even get to exist beyond that term, right? Whether it's trans women, whether it's a person living with HIV, whether it's uninsured, right? Whether it's someone who's a drug user, someone who's a sex worker, there's all these identities that most of us put on top of those terms, as opposed to recognizing the person behind it. Like, imagine being in that person's body, right? Living with all those terms. You don't even get to be a person yet. You got to bust through all these walls of like judgment and misunderstanding, things like that. So I feel like with every different layer of life, you add like 10%, you know, of this is a likely thing here, this is a likely thing here, you add and then you get 50%, right? So there's a lot of pieces to that. And I hope I've answered the question thoroughly, because there's so much more we could say, but I'll start there.
Yeah, I mean, like, no, this panel isn't meant to be exhaustive. I hope no one got on it and was like, oh yeah, I'm gonna learn everything I need to know. Absolutely not. And just for those in attendance, like, we really emphasize the need to be concise so that we could get through a lot of information that we want to get through, which probably means for people who are heavily vested in this, which we all are, and we all work together, that, you know, there are going to be some things that you feel should be included that weren't included, and that's where you come in and do your part in the Q&A and submit a question. So thank you so much, J. Marie, for that. I do want to open up that question to AJ or Kneeshe if you have anything that you want to add to that before we move on.
J. Marie, you did a phenomenal job with that. And it still goes back to, we are human, right? We're human beings first. And having that first concept of being first, that goes back to the language that we talked about at the beginning, you know, having that language, having that dialogue of being a human being to gain access. Also, we also know HIV is a taboo for women as well, to have those difficult conversations, and it's overwhelming too. So I am an ally for the trans community as well. And I have difficult conversations with my trans sisters, not to be disrespectful or anything. I want to pry so that I can know how I can best service and help, especially when I get a trans sister on my caseload. And I'll be able to have that language and be able to use that language well. And learning from them is the best people to learn from, because they know it. They walk it every day, they live it. So that lived experience affords me spaces where I can be there to share my compassionate feelings about the trans community, because they are human. It's not about a sexuality, it's not about a certain population. Human beings come first.
Yeah, totally. The other thing I would just say really fast is that a lot of times the work, I mean, judging by how official and kind of formal this panel is, right? This is not necessarily how a lot of trans and queer folks are living our lives, right? We talking to our homies, as Kneeshe said, whether you're trans or queer or not, we're talking to our homies, our folks, right? And are probably not jumping on a very formal, everybody got their backgrounds, you know, like muted. Like, this is just a different world that we live in, right? And then we need to do the work in sometimes. So like I said at the beginning, closing it out with like proximity, right? Returning back and not being afraid to have some rough edges, because that's where people are. People have rough edges. That's what life is like, right?
Absolutely. Antoinette, did you want to add anything to that before we switch off?
No,
all right.
What you never said was perfect.
All right, go ahead, Molly.
All right, so thank you all. So we've talked about HIV generally and why language is so important, and how to find more information about HIV if that's not already a part of your world. And we've also talked about the disproportionate impact in Black communities, but particularly for Black women and trans women. And when we look at the stigma and discrimination around HIV in and of itself, paired with racism, which is what causes the disproportionate impacts for Black women. When we think about the fact that we're also in a nation that prioritizes mass incarceration, we have a very particular and volatile situation. So Amir, can you talk to us about HIV criminalization, and specifically how policymakers and prosecutors justify criminalizing not just any virus, but this virus in particular?
Yeah, well, I think that's a great question. I mean, technically and literally, they've justified it as assault with a deadly weapon, which is ridiculous. I mean, in many states, including Missouri, there are statutes that criminalize exposure to bodily fluids, especially in a correctional setting, that really pose no known risk for HIV transmission. So I think something that plays into this is real simple ignorance about the roots and risks of HIV transmission, and especially the ignorance held by criminal legal stakeholders, because they're implicated in myths and falsehoods about HIV as well. I mean, criminal legal stakeholders, prosecutors, law enforcement can be out of lockstep with scientific and medical reality. So I think, which can contribute to stigma and really is what criminalization of HIV is built upon. So I think part of this advocacy has to be educating in a proactive way people in the criminal legal system, prosecutors, judges, attorneys, and law enforcement, correctional officers. You know, I think something that the COVID-19 pandemic has shed a light on that's also true about the legacy of criminalizing HIV and viral hepatitis and other infectious diseases, to even criminalizing sex work, is that the enforcement of alleged disease exposure has fallen on communities of color, especially Black women and men, and the poor and other people of color, people who the criminal legal system treats as disease vectors, and not as Kneeshe and J. Marie were talking about, but as people with dignity, as human beings. I think that's something really important to foreground here. And it also really touches on, I think, something that Antoinette was mentioning about the prevalence of HIV and how it relates to sexual education. Because, you know, I think it's a really necessary part of this work that deserves more advocacy and attention is the sexual health needs of youth who can't be reached by a state's education department, who can't be reached in the classroom because they're affected by the school to prison pipeline, or they're disproportionately affected by status offenses. So youth who are outside of the reach of the classroom, who are in systems, who are in, who are in detention, who are in foster care, they have rights to sexual health and literacy too. And I think, there's a lot of work to be done to really secure policies that enforce and really describe that right to sexual health care for youth who are system impacted. So I think, there's the Sexual Health Youth Advocacy Coalition, which is actually something that I get to help do with CHLP as well. So, there is a national coalition working on the issue of the intersection of sexual health literacy and youth who are in state custody. So I think that's an area that desperately needs more attention. But, I think to answer your question, Molly, the disparity in the enforcement of criminal law in general, is similar to the disparity in the enforcement of disease exposure, the criminalization of HIV. People who the criminal legal system deem as unique dangers to society. And it's tied to everything, to the association of criminality and Blackness that goes back centuries in this country.
Thank you. You included a lot in a short amount of time. So thank you for that breakdown of how policymakers can begin to justify this, because when we break it down, it seems totally absurd, because it is. So why would you say that criminalization of HIV isn't a better known problem? Because I think once you have an audience and you explain it to them, they're horrified and they can't believe that it's a thing. But so many people don't even know that HIV is criminalized. Can you speak to that?
I think the reason it's maybe not more well known might have to do with actually a reason that plays into an earlier part of our discussion about language and about getting people up to speed about medical realities, that HIV is a manageable chronic disease and not a death sentence. And I think it's because of sensational media about criminal transmission of HIV. I think, it makes it seem like it's something really marginal, and the enforcement of it tends to be, right? But the criminal penalties are so severe that they really don't match up to any understanding of prosecutorial guidelines. I mean, there's really a misconnection between the longstanding legal principle that you only prosecute people who intend to harm others and how these statutes are written. But I think part of it too, just, I'm not exactly sure why it's not more widely known, but it's a shame.
Yeah, thank you. And I think that's so true, that it does connect back to language and how we talk about HIV today. We often think about HIV as something in the past that white, cis, gay men overcame and that it's behind us, but it's not behind us. It's still very much present. But I think that erasure over time and the way we talk about HIV, I think you're absolutely right, is all connected to how few people actually know about HIV criminalization. So thank you. I'm going to turn it over to, oh, did you want to add something?
Well, I think, you know, something that might come to mind naturally is just because the face of HIV has changed over the years, there's a societal willingness to overlook the criminalization of HIV. As HIV has become more black and brown, it's easier for society to just overlook these people and treat them as disease vectors, like I suggested earlier. You know, I think that's probably part of it too.
Absolutely. So we're going to turn it back over to Eva to bring us home and connect what all this has to do with intimate partner violence.
Yeah, so thank you, Amir, for that. If I can just insert a little bit, I think, I know, for instance, again, that the people who are, you know, presenting this discussion, that we all work in HIV now, but at some point, we didn't always, right? Outside of maybe Antoinette, but even then, like, just, it depends on where you live. If you live in a state where HIV is criminalized, and even with me doing the work, and I've been active in Missouri since 2011, and I didn't know about it until I was invited into the Missouri HIV Justice Coalition. And that was what, 2 years ago? So yeah, like not even a full 2 years ago. I'm gonna give it a year and a half, so a little more than that. But and then learning about it and how detrimental the effects are. And so the criminalization of HIV and AIDS, it has detrimental effects, but I want to shift into how it specifically affects Black women. Like Amir was saying, that the face is changing, and it's similar to COVID-19. I mean, you can liken it to right now this, I don't want to say current pandemic because HIV is still a pandemic, but what has everyone, the latest, the latest pandemic, we'll say, yeah, is in how, you know, before studies started coming out that, or just not even studies, because it's actually just, you know, fact results, that people of color, particularly Black people, Latinx people, and Native Americans were dying at a disproportionate rate, not just disproportionately, but numerically dying more. And then we started seeing protests and people wanting to be outside and they don't want to wear masks. And, you know, it's whiteness in the imagination, you think about that and how that plays out. And for them, it's not something that affects me. And if we think back historically to HIV, that's a big reason why these laws were even created, and why HIV was allowed to go on the way it did. And so many people died because it was constructed as a disease that only affected gay men, and then, you know, subsequent of that, Black and brown people. So yeah, that it does matter what group gets attached to a disease and what people see, and it just exacerbates issues within society that are already there, right? So with domestic violence, we start with our starting point. Here's the statistic that 43% of Black women will experience domestic violence at some point in their lives. I feel like that's an unacceptable statistic. And it comes with a lot of issues in and of itself without even factoring in HIV. But I want to start here by starting at a really basic point. So like, I think Kneeshe, you're a good person to start with. Like, how does living with HIV impact Black women's experiences with inter-partner violence? And that's a huge question. You don't have to be completely comprehensive, but as much as you can squeeze in, start us out with that.
think intimate partner violence is a really thick topic, and it could go several different ways. I am a survivor of intimate partner violence, and being a woman who is 42 now, and that trauma happened when I was an adolescent. The way that the criminalization was back then, it was much easier for a woman to get a restraining order. I'm just going to start there a little bit. You were able to go into the precinct and show your wounds or show your trauma, and someone will be able to write up the report and get the ex parte diffused immediately for the person to be taken from the home. Now you have to jump through so many different hoops, taking an individual in or working with several organizations for domestic violence to get the young woman to come into a safe space to start there, to fill out the paperwork and get all of those things taken care of. But we never think about the family, the overall family that is dealing with intimate partner violence as a whole, because that young woman may have children, and those children may be going to school and things of that nature. Living with HIV and having intimate partner violence looks different because it's a safe haven, but it's also a trauma for some women. Some women don't know how to really say no or move on or try to access points to leave because it's a safety net for some tangibility of it, either if it's money, it could be substance, it could be just having a roof over your head. You know, to know that you're out from the inclement weather. You know, it could be wintertime, it could be too hot outside, but that's a safety net, and they will, take as much as they can, in to deal with this intimate piece of violence, just to say that I'm indoors, and it hurts really, really bad. It's uncomfortable. It's uncomfortable to talk to your doctors about it, really, and really having like that best friend. As J. Marie mentioned early on, we have life that unfolds where we do have that kiki moment, where we do talk about certain things that happen. But for a young woman that's experiencing that, silence could be just what it is. They may not have access to telephone services during that time period, feminine hygiene products, just a whole gamut of things. And they may have to sell their bodies to just keep bait, just keep quiet, just to make it to that next medical appointment. And you're wondering why you're having that disconnect, or that social worker is not compassionate when she walks in and they want to get all of this paperwork done because they're trying to tick it off their list. So you have to be compassionate and hear the signs and learn the signs and do the signs and work with the signs to make that young woman feel compassionate about her inner beauty that she may not even see at that moment. She has that inner beauty, but it's just not there because she's not even thinking about that at that moment. She's looking about getting in and getting out. I have a young woman that I've worked with in the past where we would set up a special word when I text her or call her to let me know that she's still okay. It's those simple things that you have to do. And it's no book to this. It's no book to IPV. It's no book. It's no rhyme or reason. It's the reality of what is happening at the surface. So you have to be ready to juggle those things to help that young woman through that. When she's ready for the out, she will get out. It's a timing thing. It's not something that's going to happen overnight. I would say if we have any clinicians or social workers on this session, when that young woman comes in, try to make sure that you're as comfortable as possible with her and get your paperwork filled out, but also get her the quality of care, those triple dip screenings that she may need, those labs that she may need. That's the most crucial time to work with her and get all of her refills done and make sure that she's packaged very well when she walks out of your door. Because you may not see her in the next 2 months or 2 weeks or 3 weeks. It just depends on what's going on, the days of the weeks that she's walking through those horrific moments. So that's what I can say about that. And we could go on and on and on about this topic. And we have some great, phenomenal experts in the room, I do know, but we could go on and on about this. And this is a sensitive topic for individuals to really be educated about. But if you see the signs of a young woman, you know, make sure you make note of that and be as compassionate and empathetic as possible when she walks through your doors.
Okay, so how does HIV further complicate that process specifically?
Not being able to tell what you're living with. You know, some women hide that. They don't come forward with that, you know, just to keep themselves safe. Because if you expose yourself and say, I'm a woman living with HIV, or you tell your partner that you're HIV positive, you could get struck. You could get hit. Your kid could get hit. You know, your kid could be sitting in a closet for weeks with no food. You know, so those are some of the things that women have to go through. You know, the rent may not get paid if you tell your status. You might not can go to the doctor next week because you told your status. You know, so it's a lot of rolling pieces with disclosure. And that piece of disclosure with a partner is really thick. And if that young woman knows that her kids could be possibly taken away from her, she's not going to tell her status to her partner, to her friends, to her family. So it's a lot of rolling parts. And people are killing women because of disclosure of their statuses. And that's happening in all populations, not just the Black community.
Yeah, absolutely. And that comes with stigma and people not being educated about living with HIV. So Antoinette, I'm going to switch over to you a little bit because like the question here really that I feel like we need to dig into, you know, like in thinking about how does living with HIV impact Black women's experiences with if I say it one more time, with intimate partner violence. I don't know why I want to keep saying interpersonal violence. Like, what is happening? But with intimate partner violence, and we have to think about, you know, different things like not just disclosing your status, but them already knowing your status and weaponizing that against you to keep you from leaving. So, but Antoinette, you want to approach that question and maybe like get into how, because a lot of times, okay, let me just say why this is important for people on here. A lot of times people think when things are happening, we want to think the best of people. We want to blame it on something else instead of what is obviously wrong in what's happening. So a lot of times, like when things are racist, we'll be like, no, that's economic. That's actually economic. And it's like, okay, cool. So it's racist. And so here, like, how do, you know, variations in education, wealth, and age factor into intimate partner violence rates, and you're factoring in HIV, like thinking about those intersections and how they can further exacerbate or how they can impact and have an effect?
Yes, so I think I shared a little bit of my story with you, Evonnia. And a lot of me, like what I've experienced around intimate partner violence had to do with manipulation, acceptance, and love. And just breaking those three things down, like manipulation from the partner, of course, knowing my status and aware of like what HIV is, because of course I educate my partners, but still using my status against me in different instances, or like if I try to leave, saying like, you know, nobody else will want you, or I'm the only person who would ever love you, accept you, and stuff like that. And then of course, when it comes to acceptance, it's more of a personal experience, like me accepting and loving myself enough to know that this is something that I don't need to put up with. Me accepting living with HIV was a challenge at first. It took me a long time to accept my HIV status, because I didn't have connection to community. I didn't have support groups like I do now. I didn't see anybody else living with HIV who was going through what I was going through. So I felt very isolated. So a lot of it has to do with acceptance. And then, of course, like I said, love. So how much do I love myself enough? Do I love myself enough to put up with the BS or to put up with the abuse, whether it's physical, mental, or emotional, you know? So how much am I willing to take? And a lot of those three things had to do with my mental health. And me actually having a mental health counselor, having a therapist who could help me dive into why I was allowing myself to put up with those things, and see my worth and see that I was better than that and I was above that. So just looking at it from a personal lens. And then also I want to just bring some awareness to, I heard Kneeshe say it, people who do sex work and are living with HIV. And I heard Amir say it as well. And when you're thinking about like criminalization around sex work and criminalization around HIV, then you have to think about people who are being abused, who are doing those two things. And if you are, like, how do I call the cops if I'm being abused?
Right.
How do I ask for protection when I have like two you lose situations on my end, because they're going to charge you with sex work and then they're going to charge you with attempted murder when all you're trying to do is to be protected and to be safe. So just looking at that and bringing that into the conversation is very important. So yeah.
All good points. Kneeshe, I hear you in the background. Did you have something else you wanted to add?
Yeah, I agree with Antoinette and Amir as well, and J. Marie. Like, you know, I wear a button around on my jacket, my jean jacket, and it says sex work is work. So I walked into the bank about maybe 4 months ago to deposit some money, and the teller, he was like, I like your button. I had forgot I had it on, actually. And he was like, you know, we had a conversation about sex work being work, and how the laws surrounded around it look differently in different states and different countries, you know, and how do we keep people safe, even if they have to experience sex work, you know, and how do we reduce that trauma and harm when they're in the act or have to, you know, fend for his or herself in a safe haven moment, you know, because look at COVID-19, everything is shut down. Do we have readily and available needle exchange services available for individuals who need to go into those services? Do we have readily and available AA and NA meetings for individuals? Everybody's not virtual. So you have to look at all of those factors when we're providing community services. And that goes back to our funders, right? They need to put in more money for those pieces.
Yeah, here in Missouri specifically, I think this is like what, the fourth year that we've tried to pass a PMDR bill, like to get needle exchange, and they either won't bring it up for a vote or they keep voting it down. So it's really difficult when you have people not working with facts and not prioritizing this and thinking and politicizing it, right? Instead of making it the healthcare issue that it is. So I'm going to switch this up a little bit. And J. Marie, ask you before I get to Amir, what are some things that people can be looking out for or doing to prevent or decrease intimate partner violence? And specifically maybe thinking more about how HIV ties into intimate partner violence.
Such a big question, as you mentioned earlier.
Yeah. Give us all the answers.
Obviously, I got you. No, I definitely don't have all the answers. But, you know, I think the fundamental pieces that I would hope folks walk away from today, after hearing all the different ways that folks can have things used against them, right, is the reality that we are conditioned to not believe women generally, right, when they talk about their experiences, but also, you know, we don't trust that someone has a good analysis of their experience, and that, you know, we should be supporting them when they say what's going on, right? Believe them when they tell you. So I think on the one side, it is like a cultural thing that I hope each of us, from our personal situation, wherever we are, whatever work we do, that we are doing our best to widen our lens to recognize, like, not only all the signs that people have talked about, but really to open your services again up to people who have these very nuanced experiences, right? And so I think the other piece of it is, you know, I would say just become used to or clear about some of the organizations in your area, because on the one hand, I personally, while I might be a good advocate or might know some good vocabulary words, I am not the best person directly to intervene, right, when someone is specifically experiencing interpartner violence. And I definitely get the interpersonal. It's like right on the tip of your tongue, even, so I don't blame you for that. But I would say learn about the organizations locally, and make sure, do your best to find ones that have a structural analysis of, not just patriarchy and those kind of big words, but really that the ways that sex work or HIV does add to the weight, right, of someone's desire or feeling like they have the ability to come out and say, this is what my experience is, right? And I think there's going to be some very specific avenues that are probably not being used right now, as far as like social media, right? And people doing sex work or people doing things that are not just going to come on a webinar. You're going to have to kind of up your social media game in terms of, I appreciated Kneeshe's comment when it came to having a special word, right? There are going to be a lot of things that are not going to go through formal channels. So you and your staff and you and your local folks are going to have to go through, what are some of the ways that we can create a backup plan or some sort of kind of back end way to recognize that people might need to come in the back door. It can't just be, saying, here's our front door, everybody come tell us about your business, right? It's really got to be, hey, we can be discreet, come through, let us know what you need, right? That's got to be a different perspective when it comes to the realities of somebody's kind of the multiple layers that they're holding in their experience.
Yeah, definitely agree. Thank you so much. And so Amir, my newfound friend, the academic in me made me come up with this question, but I feel like it's really important too, and like thinking about specific studies and research that folks could find to read for info on more information about this. So the overlap among like HIV, intimate partner violence, and the criminalization of HIV. Like, what are there any specific studies or research out there that people could turn their attention to learn more in-depth information about this?
Yeah, I also don't have all the answers, though. I also come at this work through academia, actually, Evonnia. So it's cool to know that. I studied philosophy. I was a graduate student, and I studied like the philosophy of race and the intersection of state violence and that kind of thing. But to answer your question, I'm not aware of any specific research. I think a lot of the information that's out there is anecdotal so far. I mean, we get this kind of information from news and media reports where we maybe hear about some of these like higher profile cases. But I think what I would like to say is really add to what Jay Marie and everyone else was saying, is that there needs to be a recognition that women routinely engage in sex work because of economic necessity. And that recognition that women periodically engage in sex work is something that really needs to come to the HIV modernization movement. There needs to be recognition and an acceptance to look at some enforcement data that we do have that do play into the interlap of intimate partner violence and HIV criminalization, like the Williams Institute report data, which shows in states like Georgia and Florida, for example, specifically Florida, Black women were like twice as likely to be convicted of an HIV criminal offense. Sex workers are overrepresented in arrests and prosecutions there. So these are the types of people who, I think, exactly as others were saying, can't exactly confide in law enforcement, and for fear that something could be turned around back on them, or because they're themselves engaging in sex work. So I think what that then plays into is something which should be, I think, a part of this orbit too, which is 6 states require sex offender registration within HIV criminal convictions. So not only are you maybe facing felony conviction for sex work with while living with HIV, things that will really disrupt and your access to custody of your children if you have children. But now if you're on a sex offender registry, this public database which really just exists to shame and stigmatize people living with HIV, it's going to disrupt access to housing, education, social services, employment, all these things that then, you know, it's like this vicious cycle that play into health disparities, bad health outcomes, more likely to maybe encounter violence while incarcerated, because being incarcerated is bad for health, period. So, yeah.
No, I think that's good. That is something we really didn't get into, the criminalization of HIV in the depths that we could have. I mean, we talk about this regularly, and it's not, and I do want to say it's not because we're taking for granted that people know what that is or what that means. It's just that we had to pick, you know, what we were going to focus on and what was most important to focus on to get through as much information as we could. But honestly, all of this is relevant. I think that we've touched on everything and done a little bit. I do want to remind people, if you have questions, to drop them in the chat box. If you're online on your computer, if you are on the phone, if you could do me a solid and maybe write down your question so that you can be as concise as possible if you have one and you want to ask it. We have one more round of questions for the panelists, and then we're going to open it up to the audience. So, Molly?
Yeah, so to kind of round out our panel today, we're going to ask each of you to answer the following question. So what should people interested in doing something, what should we start doing, and what should we stop doing? And what types of organizing or advocacy initiatives should we all know about? So Antoinette, if we want to start with you.
So some things that I could think of to start advocating, like for myself, I just did it. I just said, you know, forget how everybody else feels. I'm just going to do it. I knew that by me starting advocacy, I was going to be going public with my status, but I just couldn't be silent anymore. And as I've moved through advocacy, I learned, of course, there are different roles in advocacy. You don't always have to be at the forefront of everything, shouting, screaming, rallying. You can be somebody who is making signs. You can be writing policy briefs. You can be doing different things. Like, there's always a need or a role for you in advocacy in some way, shape, or form. And there was one more thing that I had, but I totally forgot. So definitely. What was your last question, Molly?
And what are some specific advocacy initiatives that you would want all of us to know about?
Yes, so especially for youth, because like I said, I focus on youth. There is Advocates for Youth who I was actually a part of for the past 2 years. They have their registration open for their cohorts for this upcoming year. And Advocates for Youth is basically like empowering young people, giving them the tools and the necessities that they need in order to go out into the world and advocate, whether it's in their local town or state, or all over the world. And I benefited greatly from Advocates for Youth because, like I said, it just gave me different opportunities, it opened doors for me. It's allowed me to find a voice and to share my voice with others. And then you also get paid for it. And I'm an advocate for paying people for their time. So if you know of a young person who's trying to make some money, especially during this time, and you feel like that they would be perfect, send them to Advocates for Youth. And there's different cohorts, whether it's around abortion access, whether it's around the one I was a part of, which is ECHO, engaging communities around HIV and AIDS organizing. I was also a part of Reproductive Justice Coalition. So there are many, many different cohorts that people can be around. So.
Great. And what about you, Kneeshe? What would you say? What should we start doing? What should we stop doing? And what advocacy initiatives should we know about?
I'm going to take this backwards. Initiatives that we should know about. We should know about International Community Women in North America. I posted their link there. Positive People Network USA has been a platform for me to learn about policies, advocacy, bird dogging. I can't wait to go to the next boot camp. I'm jealous. They had one and I couldn't make it. and being the lens, like just jumping into those small caveats that you may be vulnerable to jump in, but you'll learn a lot. So Empower Missouri has been a phenomenal platform for me to learn hands-on, visually, and in newsletters. So join some teams. Positive People Network, LLC, founded by Alicia Trammell, is also an awesome way to jump in and get on some of those virtual platforms, even if you don't want to show your face. Just jump in and be there and learn and educate yourself. Something that we need to stop doing as individuals, as human beings, is labeling human beings. Breaking barriers. We need to start breaking those barriers, but stop putting a halt to breaking those barriers because it feels uncomfortable, right? If we change a law, or we change a bill, or we enhance a bill, or we take away a bill, did we do anything wrong? No. So don't get me started on the advocacy part, because I could go deep into that, and I don't want to deter people's feelings about things. But advocate, vote, complete your census if you haven't, turn in your absentee ballot if you haven't, be at the polls, register those 18-year-olds. So since they were quarantined, they have to raise the ballots for the votes and make sure that they are there and they're being counted. I can say that. And what I want to do as an individual, I want to hone in on the health literacy for young people. We talked about the children and family services homes and things like that young people are in, and they are waiting to exit that 18-year-old exit plan that they have, but they don't have any substance or life skills that can afford them to walk before their community. So hopefully that I can bridge that gap. And if we have any team members that want to help me along and write a grant and try to get those things sorted out, I'll put my email address in the box, and that's what I want to start. I want to bridge those gaps among those young people ages 13 through 29. And then hopefully I can help bridge the gap between young women ages 40 through beyond, HIV 50 plus or allies. And my trans sisters are always welcome.
I see. So giving yourself, what, 2 more projects in the last 3 minutes? That's all you need is more to do, Kneeshe. Yeah, so same questions for you, J. Marie. Like, what should people interested in doing something start doing or stop doing? And then what types of organizing advocacy initiatives should people be thinking more critically about?
Absolutely. Well, thank you for everybody's comments. As we've ended, I know the hardest part can be, well, what do I do now? We have all this information, right? So thank you for your really in-depth answers. And Kneeshe, don't be doing too much. But I would say the simplest answer I can give right now is, I think just being present, of course, is beautiful today for those of you who are here, if this question is, speaking to what you might do next. But I think stop doing, probably just stop thinking that it's a issue that's done, right? Stop thinking that this is something that we aren't playing into by our everyday silence, right? That we actually have a role to play. And, I think every webinar you're on is like, raise the flag, right? And so I think many of us might be overwhelmed with all the different issues we should possibly be talking about. But I think your presence again today and the work that you do regularly is so important. And I would just say, remember that if there isn't anybody there talking about HIV, you could be that person. Talking about, living with HIV, you could be that person. If there's an LGBT issue or a trans conversation happening and nobody is talking about HIV, you could be that person. So I would say those would be the start and stop. And then what kind of organizing initiatives should people be either thinking more critically about or participating in? Some of you might've seen, I was kind of messing with my video. I don't think it's gonna work super well with the setup. But basically one thing I wanted to put on the radar for folks is that I know we've talked about sex work a lot on this call, and I know that a lot of people don't tend to know how to plug in when things like that start to get talked about. And so I'm pretty excited to be a part of a group that is actively starting a conversation and getting folks to the table around sex work so that we can be a group of people who don't shy away from this topic, right? And people who are recognizing the many ways and then bringing that to the surface, right? The many ways that people are targeted, are left to be unhealthy or left to their own devices. I'm going to try and pull this up for the last few minutes, but I'll definitely let people get to questions before we wrap.
Okay, what's the name of that group?
Well, the group's going to decide. I'm just saying the effort is going to get started. Right for now. For now, we're referring to it as Decrim the Hustle, because you know what I'm saying, it's what we got to do sometimes. It shouldn't be something that's even a criminal act at all. And so decriminalizing sex work is going to be, I would say, the focus of the group in terms of some of the ways that we want to orient the conversation, as opposed to like legalization, or because we know that leaves certain people available to still being caught in the crosshairs of criminal activity or criminal, crackdown. And then, but yeah, it's just like a sex work coalition for now. We're going to talk more about it, but the summer is going to be pretty busy for the group, even though it's kind of just getting started. So we have some roles that might be paid in the work. So there's a lot of things developing, but I'm going to try and get this up. And there's a couple of info sessions. One is next week, and there's another one the following week, and then we'll really kind of hit the ground running in June, early June. So let me get this up. But yeah, thanks for asking about that, and I'll hopefully get this picture.
Oh, that sounds super dope. All right, Amir, wrap us up. What should people interested in doing something start or stop doing, and what types of organizing advocacy initiatives should people be thinking more critically about?
Thank you. I guess I will also start with maybe the stop doing or something that we can learn from. I think we should learn from, so we don't repeat the same mistakes, learn from advocacy strategies and that we've seen in Michigan or in Iowa and even Florida. I mean, we don't, something not to do, don't leave people behind. Don't leave sex workers behind. Don't leave people who are directly and even more affected by these laws and policies behind. Engage them. Maybe be the person in the room, as J. Marie said. I really liked that. More cross-movement organizing and tapping into sister movements and networks, making connections with reproductive justice, to comprehensive sex ed and how that relates to the overrepresentation of youth of color and LGBTQ youth in detention and in state custody. So, I mean, it's all parts of each other. I think engaging more engaging criminal legal stakeholders actually is something, it's a harder pill to swallow. But I think making friends, if you're in the work of HIV criminal law reform in your state, which I imagine many people listening are, making friends with local prosecutors, it's a tough pill to swallow, but they're an important piece of this, and because they'll end up being a huge hurdle if we don't. So if we don't do, something else not to do, less defensive education about HIV criminalization and more proactively educating these decision makers about how irrational their ideas are about HIV. Proactively educate them about the roots and risks of transmission, and then let them understand why these statutes are so irrational and stupid. And not to mention violations of justice in every way. I think some more concrete things would be, I'd love to maybe speak to you about joining the Positive Justice Project Advisory Group. So I kind of just help facilitate that group of people who have direct experience. It's a volunteer group, but we do provide a stipend, a small stipend. We're we may be a national organization, but we do not have a big budget. But we do provide a small stipend to our advisory group members. And the idea behind this advisory group is you get to bring your expertise from whichever way it comes. If it comes because you're engaged in sex work, or you work in harm reduction and needle sharing, or you work and know and have experience with HIV criminalization, or anything, I think you get to come and bring that expertise and guide a national strategy and a national movement to end the criminalization of HIV. So, yeah.
Great, thank you all so much. And something that attendee Tammy, who is with the Zero Project and is tuning in right now from Iowa, Tammy dropped in the chat a fact sheet from Positive Women's Network around National Day of Action to End Violence Against Women Living with HIV. So I just dropped that in the chat again because it got kind of buried. But another piece that I'm going to drop in the chat for everyone is also a resource from the Positive Women's Network addressing intimate partner violence, HIV, and the current COVID-19 pandemic, and how folks who are living with HIV have to be thinking through all the things like accessing their medical appointments, making sure that there's access to medication, and also if you're experiencing IPV during this time of quarantine, that's a whole other added layer. So Positive Women's Network has put together a really, really amazing resource toolkit. It's that second link that I just dropped in here. It includes blogs by women living with HIV who are also intimate partner violence survivors, all kinds of resources for navigating this current pandemic. So all kinds of things that folks can do. And I see that J. Marie also got that image pulled up. So if you want to learn more about that, there's J. Marie's image with the Decrim the Hustle initiative as well. So with that, we only have about 4 minutes left. Does anyone from the audience have any questions at all that you would like to pose to the group? And please drop them in the chat.
I did see someone write something about transitioning from perinatal care to adult care. And I can drop my email address and contact information because I do facilitate youth cabs around transitional care and what that looks like for people who are either born positive or diagnosed at a young age, and how they process that transition or what's some best practices for that transition. So.
Great, thank you. And we have a question from Megan. How is the rising incarceration rate of women related to IPV, or is it? Would any of our panelists like to address that question?
What a question for the home stretch. That is really, really great question. I definitely want to take some time to do more research on making that explicit distinction clear. But I would say, similar to the ways that interpartner violence is heightened because of people who have multiple intersections, right? That means that you're also at a heightened intersection of chance for you to be targeted by the criminal justice system in general, right? So that's one thing, as well as, you know, if you are either a drug user or engaging in other types of activities that are, you know, proximity or proximal to the criminal justice system, you're going to get caught up more easily inside of that. They're going to want to see you go down, so they're going to find a way to bring you down. And then I would just say it's, you know, more and more women are obviously like having to take care of everything, right? As families and a culture doing it for everybody at once, except for ourselves, right? Except for people who identify as women or experience what it is like to be a woman. So I think it's just a very specific overlap of all those things, as well as, you know, again, women getting caught in the crosshairs of things happening to the person who might be bringing them that violence, but they get kind of pinned with the charges or go down for somebody. I think we all know that that's pretty common within our folks. So that's all I'll say in the last 30 seconds.
And a follow-up question, are women getting assault charges more now for defending themselves than before?
I can't speak to that directly. Amir might have a criminal justice kind of angle on that, but I wouldn't say I have a specific answer in terms of the data offhand.
Yeah, I would also have to look at some data more specifically. But, you know, again, I think it's hard to speak about these things because we know about them oftentimes because of how the lack of transparency with law enforcement departments to get this kind of data. We often only know about them anecdotally or because they're like a big like national case. But yeah, I don't know.
Yeah, and I guess I would add to that that we know in looking at the HIV criminalization data in Missouri, we know that sometimes things don't get coded consistently in police departments or in prosecutors' offices. And so there might be things that have happened in people's lives that are not documented within our systems. They only exist here and here. And so that's all the more reason that we need to be centering the most impacted folks to speak up and tell their stories, because sometimes data just isn't, it's not going to capture everything. It's not going to tell the whole truth. So that's a really good question. And it would take us a whole other panel to really dig into that, I think. Yeah. Well, it is 5 o'clock. I want to just give a major shout out to our panelists today. Thank you all so much.
Thank you.
Eva, I don't know if you want to close us out.
Sure. If you live in Missouri, join the Missouri HIV Justice Coalition. You can do that by going to our Facebook page, maybe sending a message. It's Missouri abbreviated, the state abbreviation, HIV Justice Coalition. And if you are wanting to become more involved in reproductive justice work, consider joining our email list at Reproaction. We send out a monthly newsletter, like this was on it. We try to keep events going and very informative things and arrange and thinking about these things intersectionally. Also, shout out to the HIV law and policy where Amir is. You can look on their website, which is hivlawandpolicy.org, and SisterLove Incorporated is sisterlove.org. It's primarily Black women working, centering Black women for Black women, and it's another reproductive justice organization. Yeah, Kneeshe's dropping her information in the chat box. That's what's up. Kneeshe does a lot of incredible things. I think that's everybody. Kneeshe also has Kneeshespeaksstl, and I believe that they have a Facebook page as well that you can check out.
Yes.
And yeah, that's it. I just want to wrap it up to respect people's time and thank y'all for attending, and hopefully stay tuned for more topics and great work that we'll be pushing your way.
Bye, everybody. Good evening and stay safe.
Bye.
Thank you all.
Thank you all. Bye.
Marley, do you want us to stay on?